Hello and welcome to Yashoda Hospitals. I'm Pratyusha Chaudhary, hosting for today's webinars on nursing education and training, which is live on Facebook every Thursday at 3 p.m. And thank you all for joining us today for the webinar, which is really important, where clinical handoffs is one of the most critical steps in a patient's journey and is also a core skill that needs to be taught to all the healthcare professionals. Handovers, however, it is often poorly performed with critical details being omitted and which are irrelevant sometimes, as the standards are being improved and structured, where we have got ISBAR as a super good tool. With that, whether the outcomes are being improved or deteriorated. So let us discuss more about it through this webinar on improving clinical handoffs in nursing through ISBAR. So let's dive deeper into the improving clinical standards. So I take the privilege of welcoming our expert panelist for the day, the very dynamic GM Nursing, Yashoda Hospitals High-Tech City, who is a rare combination of a beauty with brains. I welcome Shanti ma'am to join us for today's webinar. Looking forward for your valuable points, ma'am. And I'm also glad to introduce our speaker for the day, Ms. Sonia Michael, who is the AGM Nursing, Yashoda Hospitals Malakpet, who holds a vast experience in clinical expertise, and also she holds a couple of years in administrative role. So I request you to take over the webinar.
A very good afternoon to all. Thank you, Shanti ma'am, and thank you, Pratyusha, and also thank to all the dignitaries attending this webinar. As every one of you all know, the major challenge in nursing day-to-day life is handing and taking over. So let me take you all into a short journey on the importance of clinical handoff and how easily it could be practiced in our daily life and in our duties. So before that, what is an handover? What is an handover? Handover is nothing but the process of passing patient-specific information from caregiver to another, from one team of caregiver to the next, or from caregiver to the patient and families for the purpose of ensuring patient care continuity and safety. So, before I start, let's look on to the brief discussions that will be done today in our webinar. That is, how important clinical handoffs is, what are the different types of handover, the barriers and the standard tools for clinical handoffs. What are the different types of handovers? There are 4 different types of handovers which we do practice in our daily. That is group handover, a bedside handover, break handover, and an interdepartmental transfer handover. So I'll just take you into a brief of each of these handovers, so that which help us to know the difference between what are these handovers and why are they being differentiated with different names and why do we practice this. So first is a group handover. Group handover is otherwise known as a shift brief. This happens in a designated area where a commencing nurses who are coming for the shift duties join together in a group, and in this the brief is being shared by the nurse manager or shift in charge. This includes in brief about the potential issues or any other issues related in their unit so that the staff has been prepared accordingly. For example, during this type of handovers, a brief of every patient is being stated. What were the complaints, what were the issues they have followed, what were the issues they have responded, and the complaints during the e-shift is being addressed in this handover so that the commencing nurses who are coming for duty get mentally prepared to face such challenges and overcome patient-related issues. Bedside handover. Bedside handover is nothing but the shift handover which happens during the shift change. This plays an important role in every nurse's life because bedside handover gives the best output of patient care. Henceforth, bedside handover also gives us an opportunity to make the patient and patient attenders also be a part of this handover so that they are also being aware of the plan of care for the patient for that shift. But before this, do remember, any bedside handover needs to be done the following formalities, like the patient should be identified by two identifiers, that is the full name of the patient and the IP number. But not only the identifier, what to be included whenever there's a bedside handover. So there are few examples or few factors which I'll be defining you. One is the clinical alert. Clinical alert is nothing but how you assess your patient, whether your patient has been prone for a fall, is there any medication errors or missed dose which has happened from the previous shift, or any catheter which has been delined, or any medications or any complaints of the patients could not be addressed can be identified during a bedside handover. Whether a patient has been posted for surgery, if so, are the orders followed? Are the surgical profiles sent? Is the preparation been done properly? Is the patient on NBM, or is the patient being educated regarding what is being going to happen to the patient? Does the patient has any queries related to this? Can be cleared. Any pending investigations or due reports. Due report specially specifies any special investigations, which is major part because that helps out in giving further treatment for the patient. Because if due reports have been not collected, that may delay in medications and which may worsen the patient's stay in the hospital. Any procedures or any referrals pending, medications which are supposed to be given have not been issued, or it's been not available, or it's been not given, can be clarified during bedside handover. Patient complaints, yes. The main concept, the main thing of bedside handover is the patient identifies or try to know what has happened, what care has been given to the patient, so that he'll be also aware that this and such procedures have been done to me throughout the shift. Short break handover. Short break handover itself means to make us understand a break where a sister needs to leave her ward, leaving the other patient in the ward and move out. Move out means nothing but a patient need to go for an investigation, or it can be a shifting to an OT, or it can be a radiological investigation, or a sister needs a break because of too prolonged duty timings. Henceforth, during this handover, we do request all the concerned nurses to give a small brief about the patient which is left over in the ward to the nurse manager or to a shift in charge, so that the patient care is not been hindered, nor the patient feels that there is nobody to attend the patient. The patient care continues and the patient also feels satisfactory. Henceforth, say that short break handovers should be followed, whether it is for a short period or whether it is for a long period. Interdepartmental handover. Interdepartmental handover is nothing but when a patient has been shifted from one area to another area. It can be, for an example, a patient has been shifted from an ICU to ward where the patient has been recovered. In such type of handovers, same thing as common bedside handover need to be followed. Patients must be identified by the two identifiers, that is the full name of the patient and the IP number, including that few more alerts to be followed. This happens when the sister in charge taking over from the ward needs to just concentrate on the following factors. The case which has come from an ICU or from another level of areas. How conscious is my patient's level? Is my patient prone for any injuries? Do my patient requires a brief detailed assessment like fall risk or Braden scale assessment? How continuity of care does this patient require? Is this patient on any oxygen? Is this patient on any catheters? Does this patient require a special care? These need to be followed up. Then the special orders. Is anything been missed or which needs to be followed? Any things which are pending which needs to be followed up? Any planned procedures, any referrals, especially the concerned sister who's shifting the patient should also assure that before shifting the patient, the medication part of that has been completely checked and see that the patient has been administered with correct dose and correct quantity of medications before it's been shipped out to another ward. This helps us out in analyzing whether there was any medication error or some missed doses. Even though the sister in charge who is taking on to the other ward also assure that the patient has been given with proper treatment and proper on-time dosage administration. And also, it also helps us in reducing the patient complaints. And see that these handovers are also done at bedside itself, so that the patient will be aware of this care given in an ICU. Something can be missed, which can be guided up also by the patient itself. What are the barriers in our clinical handoffs? Yes, we do have barriers in our clinical handoffs, and this is a daily concern where we need to gear up ourselves. Nurses must be aware how to gear up such handovers. For example, if I say you all a physical setting is nothing but the environmental causes which causes during the handover. The barriers which happens, for example, it can be attending a call bell when the patient suddenly rings, or a sudden emergency need which a patient has been required, or it can be a telephonic call, or it can be for what you say, a query or something related to patient concern. So these are the common barriers which we face during our handoffs. So we all should be aware that how can we prevent such types of handoffs. Towards such type of handoffs, see that the situations have been taken up and the handover has been taken in a proper manner. Sometimes the example, a sister taking up an handover, a nurse taking up an handover feels that, yeah, I'm aware of this patient. I do not need a brief of this patient. No, never do that. Because what happens, what plan of care must be known. Then only a continuity of care will be given to a patient. Social setting. Social setting is nothing but the interruptions, how the interruptions between your handing and taking over process. Social settings is been example of a area where there's too much of crowdism, too much of interruptions during your handover, too much of people roaming here and there, which you may do cause handovers improperly. And this also make us understand that in such situations, go in deep and a brief detail of handover so that already we have been distracted with many other concerns. So see that everything has been referred in during these handovers. Language barrier. Language barrier is nothing. It's been considered as a major cause in nursing handovers. We have staff nurses who are coming up from different places and different areas. So language barrier can be potentially decreased from the interpreters. Interpreters is nothing but a list of people who are aware with the common languages. This, if possible, should be available in all areas because any barriers can be helped out of this. Because there are some sisters who may know only Malayalam. There are some sisters who only speak Tamil. So the common language would be English. No, if they feel that they could not speak out in English too also, they can use this barrier technique, which is called as interpreters list, which help us out in identifying the needs of the patient and communicate as per that. Now, what are the mediums of communication? See that always communication is in a direct format, not in an indirect format. It should be properly clear, it should be concise, and it should be written. See that verbal communications have been avoided, and if so, verbally has been communicated, see that you follow a readback mechanism so that the interruptions of handover and patient care is not being deferred. One of the best part and the best tool for the handover is nothing but ISBAR. ISBAR is a best practice of patient handover because it helps us in knowing the situations from where the patient has come, with what symptoms the patient has come and everything. So let me give you a defined brief on what do you mean by ISBAR. ISBAR stands for identification of the patient, situation, background, assessment and action, and response and rationalize or recommendation in the other words. Identification, as I said, you need to identify the patient with two identifiers, that is the full name and the IP number. But before identification, you need to identify yourself to your patient, that is introducing yourself to the patient and telling what are your roles and responsibilities for the day with the patient. Situation is nothing but with what symptoms is the patient in the hospital. Is he having any type of pain or any problems which has been concising for the day? And how is his level? Is he concerned? Is he conscious? And how good is this? Next is the background. Background means the history of the patient. With what history the patient has come, what medications were he, does he has any past history, is he on any medications, what is has been diagnosed in the previous. Assessment part is a major part. It is the head to foot assessment where nursing needs to know. It includes the patient's skin assessment, the patient's present diagnosis, as well as identifying the care to be given to the patient in the further needs. Recommendation is the pending things which needs to be followed through the next shift, or you need to plan accordingly. For example, any treatment wise, any investigations or any collections of reports are being pending.
Pratyusha, you're there?
Thank you, Sonia, for Thank you, Ms. Sonia, for the most elaborative yet simplified session on clinical handoffs in nursing. So the panel is now open for the discussion. We request all the participants to place your queries or questions in the chat box so that we can discuss more about it. So, Shantima, we have got few questions for the discussion.
I think because due to the echo sounds, Sonia can mute herself.
So it is the first question is like, why clinical handoffs are vital for nurses?
Thank you, Sonia. You provided a very beautiful insight on the professional mnemonic called something called ISBAR. This is one of the very structured handover format. As I think 7, 8 years or 10 years ago, this started in the year of 2003, I guess, and it was started by USA, and it was firstly seen in military and navy kind of campaign time. But then, thanks to the accreditation law, who enforced and strengthened that these kind of structured format should be introduced in the healthcare professional settings. So I'm ready to quote. You can dejoint the question sessions to me so that I should be helpful to the nurses. You can just go ahead, Pratyusha.
Why clinical handoffs are vital for nurses, ma'am?
The healthcare setup is very dynamic and complex in nature nowadays, and a patient, as they are our prime stakeholder, and to gain their knowledge, their trust, we always need to communicate. So the structure format, which is aligned in our patient record, which is very concise, and I think every nurses should be taught in how should they communicate with the patients in such a scenario, because these structure formats, whatever the elements are there in this process, it is very least taught. And nowadays only we are just getting the awareness on, let's say the senior to senior nurses handover would be very easy, but among freshers it may not be that easy. It may be very difficult because of their different
expertise. Yes.
So it should be taught, it should be practiced.
So can we discuss more about the core handover problems that we see would affect the patient safety?
If at all the nurses, if at all, let's say what we have is plan of care. So always we need to be organized. I know because of the nurse patient ratio, sometimes we do not match the compliances, but I think the plan of care, the plan of interventions should be organized in such a way that everything goes hand on hand, and patient safeties are not compromised.
Yes. In case of the problems, as you quoted before, like the fresh nurses, the novice nurses will have more problem compared with the expertised one. So in case if those are the situations, what could you say, what could you suggest as for a good handovers, even for the junior most too?
See, if you look at the juniors who we termed as a level 3 or level 2, especially because level 2, level 3 nurses who are very, fresher nurses, first 1 to 3 months, we do not assign them any sort of patient handover. Before induction or after induction, before induction, they just get to know our system. After that only, we just give them some case scenario. So I think this case scenario should be taught. I mean, these elements should be taught. The, hands-on training, senior nursing personnel asking them case scenarios, all different factors, and the communication, because why they are not able to give, because of their communication barrier. So I think we must have a lot of patience. We seniors, we all should have a lot of patience in giving them a lot of training, knowledge, give them a lot of assurance so that they can practice and perform well.
Yes, as you said, like the mentoring plays a major role from the expertise.
Yes.
And in case if we see commonly, when we see the nurses during the handoff times, we see sometimes they will be burned out, and it is the most commonest one sometimes we see in the critical care areas or in the wards. So what could you suggest to bring out the, take out that chaos situation on the burnouts for the nurses regarding this handoffs?
Yeah, that's, I think, very, very great and very good questions, because sometimes I have witnessed when I, walk into the corridor, I see nurses are tensed. I see every desk, there are two nurses who are talking, conversing with each other with the patient file. And as per protocol, we talk because a breach of confidentiality should be maintained, not by the bedside, unless until patient gives the decision making or clinician gives the decision making in doing so. We see nurses talking a lot, but I think they should be allowed with a lot of time. They should not be tensed. They may be tensed and worried about their, transport, which is just held. And they are a lot of distracting factor, as Sonia clearly said.
Yes.
Phone calls, okay, and maybe the clinician comes for the rounds, so maybe a wound dressing, maybe a patient or different other patients got crashed, or maybe a patient diets are not been served, and then there's a call bell requiring nurse to come and respond to the patient, or maybe lapse of patient interventions, maybe 12 o'clock what we are supposed to do, but by 2 o'clock it is not been done.
Yes.
So these are the factors where I think the nurses are not organized, and that's how the burnout factors are not only the lapses or non-compliances practices only by the nurses, but lot other contributing factors, like as Sonia said, environmental, and then nurse patient ratio as well. I'll say senior to senior nursing handover would be just done within 15 minutes, but again the nurses, when they join the shift, they have to check the inventory, they have to respond to a few call bells, they have to check their dues, and so do they have to take the handover. So these are little and more tensed situations. Yes, of course, within this level 3 nurses are, if they just cope up, that's very great. Otherwise, it still remains challengeable for the novices nurses.
As you said, like the novice nurses are having all these problems as per the expertized, standardized tools that we have got, as Sonia has briefed us about ISBAR completely. So do the structured tools will help us decrease this burnouts?
Of course. I just wanted to, put my insight here. Maybe nurses before 10 years back, they would only narrate the descriptive approach in a very generalized way. Yes, I have received the patient, medications given, vitals marked. But nowadays, these structured, which will always say right from the demographic details of the patient till the toe assessment, everything is very structured, and you cannot skip any eye detail out of the patient's case scenario. Yes, these tools are very helpful.
As this ISBAR tools are talking a lot, like we always train our staff on ISBAR tools, like identification, how they have to identify what is the situation and all. But still, how that will try to have a good impact or outcome from the patient safety side, as communication is being the first super top tool that we have in the IPSG goals. So how does this ISBAR will be helping us to bring out the best patient outcomes?
So here I would like to again refocus and request and urge all the nursing fraternity that if you practice all IPSG goal, all 6 goals, I think we will not have any sort of problem. Yes, if at all you talk about ineffective communication, which is our second very supreme and prime, IPSG goal. Let's say if at all I want to introduce myself, I do not do this practice. I might just say hi, hello to the patient, but I do not identify the patients in terms of calling the patient name, looking and cross-checking it with the ID band. So I think if these IPSG goals are practiced, and you have to involve the patient and attenders in the decision care making, especially in the transition care scenario. Do communicate whether whatever language maybe, because it is a Telangana setup, so everybody is very comfortable in speaking in Telugu. But language barriers, you can always ask, seek help from the seniors. But I think it should be communicated well to the patient so that there is no concept of doubt and misconceptions. Otherwise, again, there is again challenge in the scenario. Yes, and conflict as well.
Yeah. And do you recommend any kind of nursing journals which are talking about the handoffs and any recent changes or additions that you wanted to say as about the clinical handoffs?
I think when we were, initially we were practicing in this structure format, and every hospital have, remodified this format, and with the time now in this, JCI era, or maybe Joint Commission and International Accreditation also says it should be liaised with a reassessment format as well. I mean, these are my parameters I have assessed, but then I do lack in reassessing those parameters which I have marked it. So reassessment and senior nursing personnel witnessing these handover scenarios are important. I mean, the two nurses are talking, that is very well, fine enough. But then there are a lot of strategies where healthcare teams, maybe the pharmacist to the nurse to the physiotherapist, all that is lab still, so this should be brought into the practice, and training should be important.
As you said, like we doesn't need only from nurse to nurse communication will not help out but still it's healthcare professionals, being healthcare professionals, we need to have a teamwork and team briefing every time during each and every shift. Is what you mean, ma'am?
Yes.
Yeah.
Not only nurses. It is, it lies with a multi-para team, like in one ward or in ICU, there may be a 10 to 11, 12 team members who is involved in, communication. So all that adherence to the IPSD goal number 1 to 6 should be followed.
Yeah. As being the top leader in an organization like GM Nursing, for Yashoda Hospitals, do you have any stakeholder engagement activities or any communication tools that you plan to train our own staff?
Well, I only, my request is only to the senior nursing personnel, maybe my subordinate, and as Sonia mentioned, the hierarchy about senior nurse manager who are, who are there to witness their own nurses' competency and, handover styles. If they witness, the seniors also should have little patience in witnessing what the activities between two nurses are happening. How do they communicate with the patients? How, maybe the nurses are, they're, very, their emotional backgrounds are also not very strong when they are into the fresher level of tenure. So I think we all should, dejoint those, factors and joint with a lot of compliances, teach mentor to mentee, classroom scenarios, and case presentation as management and even Dr. Pawan also have, strengthened a lot of time that case presentation should be done.
Yes.
So these, likely practices will always improve the adherence to the compliances.
Yeah. As you started quoting about the stakeholders strengthening points and all, so what could you suggest us on various strengthening concepts which were not in India but still been practiced in abroad and all over globally, not in India? So what would be the concepts that you wanted to bring down to India and you wanted to make our own nursing fraternity to start doing it and make that happen? The standards you wanted to improve in the clinical handoffs.
I think nowadays we have our documentations, we are, documentation less in the sense our documentations are very precise and very, gone are the days where we used to have heaps of documentation. Now because of the accreditations and lot of other trends in nursing and being technology support in terms of computer and all the applications which is installed in the system, I think this documentation's burdens are day by day decreasing, and but only the nurses, they should be organized. We also need to have lot of patients to adequate timing to be provided to them. And of course, the classroom training session, the practical, talk outs when they want to talk, the usage of abbreviations. A lot of time they only use abbreviation, whether they don't know whether what is the mean of the abbreviation. So such a thing, if we taught them, so I think will do very well. And there won't be any compromisation to the patient safety. Outcome would be very better.
Yeah. Thank you, ma'am. And in case if we say talking about the simulations, and we globally see every time in the top webinars, when we attend the international webinars and all, they keep saying as like, it's really important for us to join these kind of simulation-based trainings that can enhance either it may be a patient scenario, either it may be a real case scenarios or a role plays that we keep happening at the hospital setup. Would that bring the change by utilizing the standard tools in the hospitals?
Well, yes, simulation, yes, that can also wait. But what I think is every day, daily, if you have a set of 40 to 50 nurses in one ward or 12 to 13 nurses, ask them only about their case presentation. Yes, the dialogue, phrasing the sentences, how to present the cases, how to align with the case presentation, assessment, keeping ISBAR in the view, that would be aligned. But then only first, let us make the two nurses talk. How? By not using vernacular languages, and confidently they should speak. So, and rest, all the factors can be always looked upon. I think we are lagging short of time now, and it is quite enough. Any more questions?
Nothing, ma'am. Thank you so much for the best support and the best discussion you made, and the crisp presentation which has been done by Sonia. I would like to thank our Director of Yashoda Hospitals, Dr. Pavan sir, for giving us this platform for exploring the nursing knowledge. Also our AVP, Dr. Amar sir, for giving me the opportunity. And last but not the least, I thank our nursing education team, which is the backbone. Also, we wanted to thank always our digital team, Mr. Pavan and Mr. Ashish, for helping us. Yes. And thank you one and all. Let's meet with the most interesting topic in the next coming webinars. Please stay tuned to us.
So let us rejoin to the midst of misconceptions towards this ISBAR. Let us join hand, and I thank even Dr. Pavan, Dr. Amar, and our foremost VP Education, who is Vimla Prasad, and always Pratisha and her entire team, Sonia, yes, everybody, and let's learn, and heaps of other updates let us put forward too. Thank you so much. Thanks.